Welcome everyone. The topic of today's webinar asks the question, why support students who are currently underrepresented in midwifery? As I was brainstorming content that might be of interest to those of us who want to promote equity in midwifery education, I thought about the amazing work of midwives and doulas on the ground. Those who are serving families, especially those who have the most to benefit from high quality, culturally relevant and sensitive midwifery care. With culturally matched providers, ideally. So you will get to learn today about the Rainier Valley Community Clinic and their Birth Bundle project. And as you do, keep in mind the importance of supporting our students so that they can become midwives and go forth offering the midwives model of care. All students, and especially those who are underrepresented in midwifery and who come from communities on the margins, are most likely to thrive when their school climates are welcoming and affirming, and when they see themselves as belonging. So again, thank you all so much for joining. Please feel free to ask any questions in the chat box. And let me go ahead and introduce our speaker today. I have had the great pleasure of learning from and with Tara Lawal. So thank you so much for being here with us today, Tara. I knew I was gonna do it. I have known you for how many years now, and I knew I was going to do it. Tara Lawal. I hope you'll forgive me.
You're fine.
I'm the worst. I could introduce my sister wrong, literally. But I had the great pleasure of learning from and with Tara as one of her instructors during her time in midwifery school at Bastyr University. Anyone who knows Tara knows her passion, her positivity, charisma, and commitment to serving the families living in the Rainier Valley is palpable and has drawn in physicians and politicians in service of their vision. I'm so grateful for Tara, who, among so many other things, came to Olympia a few years ago to testify about the importance of the Pregnant Workers Fairness Act, especially for lower income clients and those working in higher risk professions. We're lucky to hear from Tara today. She's a native of Seattle with roots from Hawaii and India. Her parents had 9 children and taught her that births should be family-centered and promote feelings of safety and confidence. As a trained midwife, she values those principles and values women as the ultimate decision makers about their care. As I mentioned, Tara graduated with her Master's of Science in Midwifery from Bastyr University and is a registered nurse who I don't know how has time for everything she has time for, now pursuing her FNP. Tara served for 3 years on the board of directors of the Midwives Association of Washington State. We got to do that a little together for a little while as well. And now she's an active member of the Pacific Islander Health Board. Tara is a co-founder of the South Seattle Women's Health Foundation and the current executive director of the Rainier Valley Community Clinic. She loves going on adventures with her sweet son, 13 nieces and nephews, and traveling the world with her husband. Thank you so much for being with us here today, Tara. I'm gonna turn it over to you. Stop sharing my screen.
Thank you. That's such a nice introduction. We really have known each other for quite a few years now. Back when I was a student and on the board, the MOS board. Okay, let me figure out how to share my screen. Okay. And then, Kristen, do you see my slides? And then, is it in presenter mode? Sorry, I can't hear you.
Oh, I muted myself, sorry. Okay. It's perfect now. Now I can just see the slide.
Okay, perfect. Okay. Well, thank you so much for welcoming me and having me be here today. It's been a long journey to get here and to be in this space as an executive director, as a midwife, as a nurse, as a mom, and now as a preceptor, and also leading a community of change. And I didn't know that's what was going to happen when we started the Rainier Valley Community Clinic. I thought we were going to start a free walk-in clinic that would, we would do a walk-in clinic twice a week and help folks out. And it just evolved and kept evolving into this beautiful practice and a beautiful space for families to be in. So thank you for allowing me to share this story of where we came from and who we are, and hopefully where we're going in the future, because it's pretty exciting work that's happening here in Seattle. Like Kristen said, I am Hawaiian and Indian, and I come from a family of 9 children. The first midwife that I knew was my dad, where he delivered the last 3 babies at home with my mom and him upstairs in the bedroom. And I always wondered, like, how did it get to that point? What happened with my mom and dad and with the healthcare system in general to have my mom not want to be in the hospital anymore? So really quick, I'll share her story, our story. She had her first 3 children in Hawaii. It was really lovely. She has really quick births. And so my dad was there. He missed the first 2, but he was there for the 3rd, which ended up being a breech birth. And the doctor actually said, "Hey, come sit right here. I want to show you what's happening." And my older brother came out with his hands and feet straight in a line, and his feet just slid right out. And my mom delivered her first breech baby, and my dad, that was the first birth he had seen, and he saw it right next to my mom, right next to the doctor. And then they moved from Hawaii to Seattle, and that's where I was born. And again, my mom had another fast birth. I'm number 4. She went to the hospital and she said, "The baby's coming right now." And the nurse told her, "Just stop pushing." And then she actually held my head so that I wouldn't come out. And my mom said, "What are you doing? The baby's coming." And my mom moved away from her and just stood up and just brought me up to her chest and delivered me by herself. And then things happened, and I ended up being jaundiced and had to stay in the NICU for 5 days. And my mom just hated that feeling. And that was the first time she had been in a situation where people told her no, and where they told her, "Your baby's sick and something is wrong with you." A year later, she got pregnant and had my sister and had my little brother. And again, she had complications, and it just didn't sit right with her. And then also, my dad now is supporting 6 children with a stay-at-home wife, and they didn't have health insurance. And so when she got pregnant again, this was number 7, they had no health insurance, and she didn't know what to do to go to the doctor. So she said, "Forget it, I will just do this at home." And she had a friend who helped her, who had told her what to do. She had a nurse friend who would just check her blood pressure and measure the baby. And so her and my dad, back in the 70s and 80s, decided to just do this by themselves because they weren't supported and they had no one else to turn to. And actually, if you look at the history of Hawaii, men delivered their wives' babies all the time. And my parents were very close and have a beautiful relationship. And so they trust each other. And so they had the next 3 babies at home. My little brothers were all born at home. And number 8 was actually a surprise breech. So my dad delivered a surprise breech at home as well. So I grew up with the notion that if things don't work out, then you got to figure it out yourself. And if you can't go into a healthcare system to help you, or you can't afford it, then you just don't go. And so growing up, we got our shots when we were little because there was a free clinic down the street, but we never went to a doctor. And thank goodness, 9 children, we never had a broken bone or surgery. And so my parents, I guess I grew up with this mentality that if you're not from this country and you don't have the resources, then you have to look for yourself and find it for yourself. And that's kind of how I did school. I went to school at WSU and just got scholarships, and I worked summers, and then I decided to go to midwifery school and did my master's that way. That you have to seek out education and you have to seek out resources. So when I was in school to be a midwife, I just put my head down and I went to work, and I had a really amazing experience at Bastyr. I'm grateful for the education and the knowledge that I learned from my teachers and my preceptors. And it was in my senior year that I was placed with Jody Lynn Owen in Seward Park. And that's the part of South Seattle where there's families who can afford to have home birth and can afford education to learn about out of hospital birth. And they had a midwife who they could trust. Many of our clients were VBAC clients. And we got to spend a lot of time with our families. And it was something I learned from my preceptor early on, that people matter, their stories matter. And it's up to us as midwives to really listen to them and understand what they want. And we have to meet them with no fear and no judgment, but with welcomeness, and to really hear what's going on. So while I was with Jody Lynn in Seward Park, we would get phone calls from the public health nurses, and they would tell us, we have a couple of families that had a quick birth. They had emergency C-sections at the hospital, and they're really struggling. Can you go check in on them? And these families come from Africa, from Somalia, from Ethiopia. And we would go in and we would check, and we would see that they had most of the time unnecessary C-sections. Most of the time things were happening to them because they didn't have any way to communicate or to say their needs or what they wanted. And that's when my heart started to really get pulled and tugged at. And that's when this vision of, why don't we just start a drop-in clinic, and we'll have a free community clinic that we'll do down in the valley, which is literally a mile down a hill into the valley. And the outcomes from 1 mile to this mile are so devastating that we decided we needed to do something. So we created the Rainier Valley Midwives, or it was the Rainier Valley Community Clinic, and people kept asking us if we treat broken bones and if we do other work. And right now we don't have a physician that's full-time. So just to keep it a little bit more simple, we call it Rainier Valley Midwives right now. We're doing business as the Midwives, so that we can build this practice up. And then as we start to team up with physicians or with naturopaths, then we'll expand back out to the Rainier Valley Community Clinic. It's sponsored by the South Seattle Women's Health Foundation that we started. It's a 501c3. We wanted to start an organization that could be eligible for grants, that could be able to help different ways of supporting the communities that we serve, the providers that we serve, and the students that we're trying to help build up. So we're dedicated to creating spaces for high quality, individualized prenatal care starting in the first trimester and ending at the third. And we provide postpartum care to increase capacity for those within the community who want to go into the healthcare industry. We especially are here to help families of color, immigrant families, and women who are trying to become some sort of birth professional, either a doula, a childbirth educator, a childbirth facilitator, lactation support, nurses, midwives, and doctors. we partner with a lot of the local organizations to be able to provide a full spectrum of care. So here are some of our providers right now. We are just about to go into a huge growth spurt in January. So some of these faces are going to have partners, and we're going to grow a little bit more. So for now, our primary midwives are Faisa Farole, who is from the Somali community. She and I graduated at the same time, and it's been a pleasure to be able to help her launch her career here in this area, and also to see how she's expanded the knowledge of the Somali community to trust midwives and to trust themselves and to want to have home birth or out of hospital birth. So Faisa was a graduate from Midwives College of Utah and has been practicing for about 5 years here with us and on her own. Faisa also started a doula organization called the Global Perinatal Services. So they specifically help women who want to have a doula that are from immigrant countries. And they also target or help the refugee population. And then our next midwife is Ceci Cordova. She's a certified nurse midwife, and she's also our lactation director. So Ceci has over 25 years of experience as a midwife. She has taken her place in our clinic as an elder midwife who we have learned to become healers. We've learned to step into this role of listening and of helping one another. And it's been really nice to have somebody with the knowledge and skill set that Ceci has of ancestral work, of body work, and of bringing midwifery and the spiritual sense of healing bodies together. So something really beautiful and amazing is happening in our clinic when we bring providers of color together. Ceci is also our lactation director. She's going to be starting an integrative breastfeeding medicine clinic where she offers frenotomies, lactation, problem visits. She can help with mom and baby. She also does woman care. And so by working with an LM and a CNM together in one practice, we have seen so many benefits. And we've seen that if we can start bridging all these different gaps, we start bridging together, we will start to fill so many of the gaps that are missing because of our scope of care. And then we also, Jody Lynn had moved away when we started this clinic, and she was gone for about 2.5 years in Memphis. And we recently hired her back. So she's our clinic director, and she's in charge of all the operations that are going on in our clinic. So she leads rounds once a week, and then she also leads a chart review once a month for our collaborative clinic. She has been a wealth of knowledge and a huge support in really getting us to a safe place of practicing with intention and with clarity and being able to work as a team. Our board is really special. Crystal Ogle was one of our early volunteer midwives who helped us from the beginning. And she came out every week to lead the clinic for about a year. And then as we started to switch our roles and we got funded from the county, I became executive director, and then Crystal became our board president. We work closely with Nellie Rabinowitz, who's been a midwife and a physician's assistant trained at Stanford University in California back in the 80s. So we have another elder midwife who is also a doula, but provides this really amazing sense of knowledge being passed on from one generation to this next generation. Allie Friedman is our board treasurer. She's also a nonprofit guru in Seattle and one of our consumers, and has brought a really critical financial goals and lens to our work. And then Clarissa Phillips is actually one of my best friends from when I was 11 years old. She and I have had birth equity training. Our equity and social justice training since we were 11, because that's what we talked about all the time. And we both ended up in work where we really fight for the rights of all those around us. And so Clarissa has her master's in public health and has spent years in Nepal and around the world in the Marshall Islands to help families. And so it was a natural fit for her to come here. She is Seattle's best grant writer and has really taken our organization to the next level by helping us to write for grants that are appropriate for us and things that we can really accomplish and do, and has really taken our organization to the next level. We partner with King County. We've received 3 different grants from the Breast Starts for Kids. We also partner with Hope Central. They are the pediatric clinic here in the neighborhood. We partner with Pacific Islander Health Board. I'm also the co-chair for the PI Health Board. And we really have a specific lens on seeing what's going on with the different communities of color who are struggling the most. And we found that the PIs have some of the most devastating outcomes. We also work with Somali Doula Northwest and Open Arms Perinatal Services. Those are our doula friends. We started our clinic back in 2015. It was part of my research project when I was a student at Bastyr, and we wanted to take a model like Jenny Joseph's clinic and what she's doing down in Miami and see how can we do some sort of collaborative care clinic that can be really easy for families to come to and get to the hospital. And so we started in a small Speedy Mart. It had been sitting vacant for years, and we talked to the owner and they gave us a good deal, and we renovated this small little clinic. And we worked with the help of over 100 volunteers to get it going. And then, like everything else happening in Seattle, the new owner saw what we did and sold it out to another company for more money. And so we were displaced from our small little Speedy Mart, and we try to keep it going. We went to a space in Renton, which is about 20 minutes from here or 10 minutes outside of the city. And we realized that there was no foot traffic. It was really hard for us to really serve the community that we are part of. And so the first thing we did when we got funding was move back into the clinic, into this zip code, and can see such a huge improvement. So why did we pick South King County? I grew up here in Seattle. I've been here my whole life. We have one of the most wealthiest people and organizations and companies here in Seattle. And as the wealth and the tech starts to come into this community, a lot of the families who can't afford to live here are getting displaced and moved, and the gentrification is so real. And it's right here in South Seattle, where we're in the middle of the nation's worst gentrification. And we have families, we have over 69 different languages that are spoken here in this zip code. So I'm in the 98118 zip code. I can see that there's a lot of you who are not from Seattle. And so here's a little map right here where we are. So a lot of the tech companies are just right here in downtown, about 10 minutes away from here. We are right on a light rail. So we're about a 10-minute light rail stop into the city. All of the money is like here in this area. I don't know if you can see my screen, my mouse, but then slowly this is where the families of color all live. This is the hub for the refugee and immigrant population. So that's why we have 69 different known languages that are spoken right here in this 1 mile radius. And we are finding that here in this, oops, sorry, let me go back. Here in this area, we have the lowest outcomes than all of Seattle. So families living in the Rainier Valley have incomes that are lower than the federal poverty level and are at higher rates than those that are living in any other part of the Seattle in the city. So as midwives, we seek to address this disparity in health outcomes by providing consistent access to care, regardless of the family's ability to pay or their insurance coverage. So our care is guided by principles of cultural humility and respect for the context of the family's life. Some of the social factors, there's inadequate support for the Rainier Valley's higher concentration of immigrants and families who speak a language other than English. So more than half of our families speak something other than English. And there's this huge barrier to accessing the right kind of care. We call this little area of Rainier Valley a complete desert wasteland. Like there are no OBs out here. There's no, our grocery store, if you go to the fruit section, has rotting food at the Safeway and the gas stations. This is the last stop for all of the food that gets delivered to our city. They come here last. And we've talked to the produce people, and food equity is a huge issue here in the Rainier Valley and Rainier Beach area. So this lack of access and this shortage is really affecting the type of care that the families are receiving. So in a city that's known for its innovation and progressive healthcare, this district is so short on providers and services that the U.S. Department of Health and Human Services has labeled it a federally designated medically underserved area. So we seek to offer, oops, sorry. I lost my slides. We seek to offer easy access to outpatient clinics. So for family planning, fertility, for teen health, public health, lactation, nutrition, and parenting support. And then here it says a lack of adequate prenatal care at the rate of pregnant women that receive late prenatal care or no prenatal care is higher in the Rainier Valley than any other part of Seattle. I'm going to send out the slides, so if you want to read these in detail, you can. Here in our neighborhood, 53% of the women are childbearing age. Thousands of babies are being born just in this area. So this is a good place for us to set up. The PI, so I'm with the Pacific Islander Health Board. We're also looking to see what's going on with the Pacific Islanders. And 31% of them live in poverty here in Seattle. 55% are receiving inadequate prenatal care, and 14% of them have preterm births. This is my little guy. He's 3 now, but you know, I thought I would be safe. I had midwives. I was educated. I had finished my midwifery degree. I thought, you know, I can make it to full term, but by 33 weeks, I started going into labor. So I was in the hospital for 7 days, and I finally told my OB, I'm like, I can't do it. Like, I couldn't even move to go to the bathroom without him having D cells. And so I had to sit in a really weird position for 7 days. And I told her, let's just plan worst case scenario and let's get this baby out on Monday. And so we planned to have the high risk neonatologist there. And we delivered him at 34 and 4. And just 20 minutes after delivery, he had to be transferred to a higher level of care. So we were separated for 3 days before I could go and see him and be with him. And my story is heard over and over and over in our city. And so now I have this even deeper desire to help our families. And we keep having NICU admissions, and this is something that it just keeps reaffirming that our community is sick. Like, we are really struggling, and there's more that we have to do. And, you know, I'm starting to get the answers here, but there's just the amount and the vastness of how much our families are hurting and struggling is just, it's really hard, and it's really personal. And it's not just me, it's my family, it's my cousins, it's my sisters that are ending up with babies like this. And then so many of our repeat clients have had unnecessary C-sections, or they've had babies born early. So it's like, gosh, all these things are happening. What can we do? Really, what is it? How are we going to change this? How are we going to make an impact in a meaningful, real way? In King County, the county that we live in, which I just found out, we are the 4th richest county in the nation. And we are having such devastating outcomes. I can't even imagine what's going on down in Memphis. I can't even imagine what's happening in Houston and at our border cities. But here in Seattle, it's pretty bad. And if we're the 4th richest county, what can we really do? So they asked us this question, and we said, we gave them a proposal. And I said, let's talk about our midwifery-led collaborative care. Let's put the midwives in charge of maternity care and see if they can get better outcomes. So I'd already done the research on midwifery-led collaborative care, where we watched other communities, other countries who put midwives as the primary provider for all maternity care. There's New Zealand, Japan, the Netherlands, Sweden. So we took that model, the things that they're doing overseas, and let's see if we can do it over here. And what we found is that when a midwife listens to their client and their client feels safe, then they will be safe. So it all starts with the mom. Our midwife will sit with the mom, and they decide, and they talk, and they say, where do you want to give your birth at? What do you do? What kind of birth do you want? What do you envision for you to be safe? Because we do know wherever a mom feels safe, that's wherever they feel safe, that's where they're going to deliver. And we have to do what Jenny Joseph says, and we have to take a step away from the perineum and allow moms to birth where they want to birth. And so it's up to the mom. Do you want to deliver at home, at a birth center, or at the hospital? Many of our moms are choosing home birth, but quite more are choosing to deliver with the physicians at the hospital. So we've So we have a formal relationship with the Swedish Cherry Hill family medicine practice here in Seattle. So Seattle has a huge hospital. We have 2 big hospitals, the Swedish Hospital and the University of Washington. Swedish Hospital is the closest one to us, and they have a family residency program that has 40 residents in their program, so it's pretty big. They all rotate through a gynecology OB rotation. And so we actually have the physicians rotate into clinic, and they shadow the midwives, and they actually learn from the midwives here at clinic. And then any mom who wants to deliver at the hospital will go into care with the physician right there. So the moms don't have to take a 40-minute bus ride with their 5 kids up to the Swedish Hospital to see their doc. They can do it right here in the neighborhood. We live 10 minutes from all the moms in the neighborhood. So they can just come to us, see the doctor, see their midwife, and then they go into care with the midwife or with the doctors. And then, since we don't get paid or we can't bill for the birth, we actually send a birth doula with them. So the birth doula will go with the physician or with the mom when they're in labor, And if the birth doula needs any help, she can just call the midwife and say, hey, I think so-and-so is in labor. Do you want to come do a labor check? If appropriate, the midwife will go do a labor check. Otherwise, our doulas are really competent and they can tell when it's time to go. So we have a protocol that when the doula says, hey, it's time to go, then we just call the red team up at Swedish Cherry Hill, Swedish Hospital, and they go to birth, and then they page our team, which is called the red team, the cherry team. They page our doc, and then our team of docs. And if one of the residents who had seen our client in care is available, then they'll join for the birth. And so we also provide lactation support. Ceci Cordova, or CNM, is our lactation support. We also got funding from King County to have some peer counselors, lactation peer counselors in clinic who could also take on caseloads and do home visits, as well as do lactation lounge drop-in in our clinic. And then we also have hours to provide postpartum doula services. Sorry, my words just got messed up. And so we call this the Birth Bundle Project, a midwifery-led collaborative care project that's delivered here in the community. And so our big goal is to really understand, here, let me read this so I get it right. Our big goal is to really clear those gaps. We really want to bridge those gaps between midwives, physicians, lactation consultants, and doulas in the community. We aim to affect sustainable, innovative change in the maternity care system. These birth bundles are wraparound care, support care services for before, during, and after birth. Every client will receive this option to have a doula present at their birth, as well as in-home postpartum service from the doula. We're providing educational services, personal lactation support, childbirth education classes, nutrition classes, exercise classes, things that we can do to really build community. Families, that's what we used to have. When you go into birth, and this is something that came up in the PI Health Board, we asked the question to some of the Marshallese families, why aren't you going to care? Like, what's happening? How come most of you are choosing to just go straight to the hospital in an ambulance when you're in labor instead of going to your doctor? And they said it's too afraid. It's so lonely. When I go to the hospital, it's just me and my husband, and they're not used to that. Back home, when you go into labor, it's a family event. Your sisters come, your mom's there, your cousins are there. Everyone comes and they support the family. Even the husband has support. His cousins are there. The men get together. And then you come here and you're all alone. And then your doctor says, your baby's heart rate is tanking. You got to go into surgery or your baby will die. These moms are like, and dads are saying, no, I'm not going to let my baby die. Do what you got to do. You're the doctor. If you say we got to do this, then let's go. Let's do this. And so this trust, they're putting trust into a system that is failing them. And that's the thing that we have to really help them redirect. One, understand their knowledge, and really understand what is there and what's available to them. So I know I'm talking to a lot of midwives on the call, and there's some preceptors that are on this call. What I wanted to do is talk a little bit about the education objectives that are happening here in the clinic. So right now, we are teaching residents. We have an agreement, a formal agreement with the residents, with the physicians, that we would provide patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication, professionalism, and system-based practice. So I'll just go through a little bit about this. We don't only do this with the physicians. This is something that we also bring these objectives into our students. So right now we have midwifery students. We have 2 nursing students. I'm their preceptor from Seattle U. And then we have the midwifery student, and then we have the residents. So and also we're starting a new program in January where we're gonna have lactation peer counselors here. So this clinic has really quickly become a space of education, of learning, and of trust. And so Jody Lynn is our clinical director, who really leads the midwives and the preceptors in providing excellent education. She teaches, and so our midwives are continually getting support in how to teach the residents, how to teach the students, so that it's not just on them while they're practicing, and because we all know how hard it is to have a student while you're also the midwife. So to have this person who is an excellent educator come in weekly and teach in grand rounds is really awesome. So for patient care, we conduct prenatal visits using the midwifery model of care. So the physicians learn the midwifery model of care. They are learning the hardest part. They're learning to take time. They're learning what to do with a full hour, because they've never had a whole hour with the patient before. And so they're learning to sit back, use their hands, use their heart to listen, and to really identify unspoken needs and concerns for their patients. For the medical knowledge, our goal and objective is to be able to explain barriers to accessing medical care that are specific to women living in this area, and really engaging our clients in shared decision-making with clients and brainstorming solutions to the barriers of care. And then where appropriate, they can conduct gyne and gynecological procedures. For practice-based learning and improvement, the residents will compare their own current models of providing prenatal care with those of the midwifery model and see where there's areas to improve in their own care. This is where it's been really interesting to learn. We believe that this is a place of 360-degree type of learning where we can learn from one another. And it's very humbling to have providers sit at the table and really try to figure out, what are we going to do with someone, and how can we give them a really good care plan. And this is the first time we even have doulas at the table. And so our doulas, when we did our first exercise where we had everyone come to clinic to learn this model, there were about, 27 people here. And we broke up into groups, and we had a situation that they had to talk about. And I can't even remember, I think it was gestational diabetes. And so this mom had gestational diabetes. She risked out of care for the midwives. She's on insulin, and they were doing a chart review, and everybody just, midwives and physicians, it's easy for us to go through the numbers and just say, yeah, she's GDM positive, she is on metformin, she's on losartan, she's on, it's easy to check the boxes. And then, we took a turn to the physicians, and they're like, all right, it looks like we need to induce at 40 weeks. So it looks like everything's ready. Let's check this, check this, check this. And then we turned to the doulas and we said, all right, what is your report? And the doulas just looked at us and said, well, this mom has a 2-year-old at home. She doesn't have a car, and her husband is incarcerated. I don't think she's ready to be induced tonight. Like, what do we have to do? Like, what am I supposed to take her to the hospital? Like, who's going to watch the 2-year-old? How are we supposed to do this? And in that one sentence, we all just kind of step back and we're like, this is a whole person again, right? And so it gets very complicated very fast. You know, as midwives, and we're doing home birth, it's really easy for us to be able to care for a client. But when we're adding this whole other layer and level of care by, you know, involving physicians and using the hospital, then we got to really communicate. And we have to really understand all the different layers that are going into somebody's care. So communication is very important. Like I said, we started off our birth bundle project with a full training and information training meeting that happened back in May. We had all the physicians, all the all the doulas here. We have about 8 doulas, and we had about 4 midwives and our students, and we were all here learning from one another and trying to figure out how is this really going to work. And then in the last 6 months, we've been slowly going through this, and we realized we need to have weekly calls, and we have to have the monthly check-ins, the chart reviews. And then in between, there's a lot of back and forth that is going on. And so the level of professionalism of what's happening happens at different levels. It's the professionalism between midwives who are leading this whole project. They're professional with physicians, and then their level of respect for doulas and lactation. And it's not just we're referring them to a doula, we're actually bringing this doula into the care team. And so we're all working together to help this one client. We all check in, and this is the first time we've ever had all this information about one person in one place at the same time. So the system-based practice is really important to be able to put the pieces together. So attending the initial orientation, attending workshops, attending, working together on continuity of care, and then initiating this contact with all the different program participants, and then just getting them to labor, right? And so this is all happening just in the prenatal period. And then a whole nother system happens the moment the mom goes into labor. And so it's a very complicated process. And so this system-based practice of, okay, the mom's in labor, it starts a whole nother protocol of what to do. And then after that, we have postpartum care. And, you know, it was really an eye-opening position when the physicians are like, how many times do you actually see your moms in labor or postpartum? Because I don't know if you're familiar, many of them will just do, if they have a C-section, they'll do a 2-week postpartum visit to check on the scar, and then they'll do a 6-week postpartum visit to just finish care and give them family planning methods. And so when we told them we see them about, 5 to 7 times in the first 6 weeks, they were floored. And so I'll give you a quick schedule. This is what the birth bundle provider schedule looks like. So during prenatal care, they can come to the midwife and resident when they're, first, it follows the regular schedule of care. They'll see the midwife and resident all through prenatal. At 32 weeks, that's when they'll meet their doula. We found that that's too late. So now we're moving things around, and we want them to actually meet their doula as soon as they come into care and as soon as they decide that they want to be a part of the birth bundle project. By 36 weeks, that's when they'll meet the lactation consultant. So we're having them see a lactation consultant to discuss breastfeeding before they breastfeed, to help them identify a breastfeeding plan, figure out when are they going back to work, how can we help them to be successful in breastfeeding. So that visit happens in 36 weeks. And then sometime between 36 and 38 weeks, they'll also meet up with their postpartum doula. And it could be their birth doula, but we're actually finding that a lot of people are fine with having a completely separate person as their postpartum doula. So they'll meet them once before birth, and then they'll meet them again afterwards. So here's our postpartum schedule. Day 1, they're in the hospital. Day 2, they go home. So our midwife will do, if it's a home birth, they'll do the 24-hour visit. If it's a hospital birth, they'll come after they are discharged from the hospital. Day 4, we have a birth doula visit. Day 5, we have a postpartum visit. And then day 7 is their 1-week visit with the midwife. So in that first week, we could have 1, 2, 3, 4, 5 visits in just 1 week from somebody, because our families that we're serving are high risk. These are families of color. These are Black women. And right now we know that they are dying at 3 or 4 times higher than other populations. So to have 5 different visits in that first week, that's when they're dying. And that's when we're going to catch it, is in that first week. So at week 2, we have the midwife come, they come back into clinic for their first clinic visit. At week 4, they see their midwife. At week 6, they can do a family planning and then end of care visit. And then the postpartum hours are all depending on what the client needs and what the midwife decides. So the midwife is the one that they prescribe the hours. Right now, we're funded solely off of this one grant. So we can only offer about 10 hours of care right now for postpartum. And so that midwife will actually be the one that decides with the mom how many hours they need. So it's a really complicated process. It's a project that has been really fun to learn and to grow from. And we expect that there's going to be a lot of different outcomes that are coming off of this project. So we, with the help of King County, what we are studying, there's 2 different studies that are going to be happening through this project. The first one is we want to know how the relationship between each of the providers are changing and growing or not growing. So we're taking surveys on the level of trust that they have for each other. So it's really interesting. At the very beginning, there's they're all unsure of what's happening, how this is really going to work. And then after every quarter, we start taking more surveys. And now we're starting to get into a really good rhythm where they meet weekly. So hopefully that level of trust between midwives and doulas and physicians and lactation will start to grow. So we have from now until the end of next year to finish this one piece. And then the next piece that we're studying is through the interviews with our clients, we're checking to see what is their knowledge and what is their level of trust in pregnancy. And we're trying to understand, are we doing the right job? Are we doing a good job? Are we doing the right thing by them where they feel less stress from their pregnancy? So we're doing a couple of different things here to try to mark, is this successful? Are there ways for us to improve? And I'll be honest, we've been working on this project for a year now, and it's taking a while for us to really get to that place. But I feel like we're finally getting over that hump. And our practice is growing really fast. And so that's the other thing, is as we add more clients to the practice, and into this project, we're hoping to really make a powerful impact on our community and real change from on the ground. About 3 months ago, we just advancing our vision and looking into the future. The city of Seattle gave us a grant to be able to build a birth center here in South Seattle. And so we are so excited. This is where I'm going to end up doing a lot of my work in the next few months, is trying to create a birth center that is led by the community. And so I'm going to be holding 10 different listening sessions with former clients, with people who have delivered at birth centers, with providers, with midwives, and then with doulas. So I'm going to be collecting the data of what the community is telling me. What kind of birth center are we looking for that's suitable for this community? And it has to be affordable, has to be accessible. We want to be able to continue our lactation support. We want to be a place of professional workforce and development. So, this is a place where the community members can also come in and do doula trainings. They can do breastfeeding peer counselor trainings. They can learn childbirth ed here within our community. And then at the same time, we're educating health professionals. The biggest mission and the reason why we built this clinic was to help launch Midwives of Color into this work. Many of us know that first year of graduating from midwifery school, it's really hard. It's hard to find a job. It's hard to find a job that pays you a livable wage, especially in a city like Seattle. It's also hard that first 6 months when you're trying to get licensed, you're trying to take the norm and then your state exam, and then you have to get onto all of the health insurances. And so it's really hard to launch a new midwife into that practice. And then at the same time, you're paying $500 a month for your malpractice insurance, and you're not seeing any clients because you're not on any of the insurance plans. So many of my classmates have quit the profession and have never been able to be midwives because they can't make it through that first year. And these are my classmates of privilege. And so I said, how are we even going to get midwives of color to be able to practice and to get them launched into this work? And so we are committed here at the Rainier Valley Community Clinic to pay for all of the overhead costs. And so as we launch these midwives into the world, we'll pay for their insurance. We pay for we'll pay for the overhead. They can use this clinic space. We'll pay for all their malpractice insurance. We'll pay for their website, for all of the design, for all of the liability insurance. We'll give them supplies. We'll give them a place of practice. We will fill their schedule, and we'll get them into the clinic. They will practice with one of our midwives who are here to lift them up into where they're supposed to be, and then they'll leave. And they'll let that midwife thrive and become an anchor midwife in their own community that they serve. So we have midwives, we have new graduating midwives that are, say, out in Olympia or in Auburn. They can come to our clinic, they can learn, they can grow, they can start a clinic. They'll have a midwife with them that will do all the billing, that will help them be an assist for all of their births, so they're not alone. That first year, we all know, is hard. So they have somebody with them that will mentor and guide them through that. And then as they start to get onto the insurance plans, and as they start to get a little footing into who they are and the kind of midwife that they want to be for their community, that midwife can just slowly leave and let them thrive and be anchored in the communities they serve. It's a beautiful plan. We, you know, as we start launching these midwives as they graduate, it'll take about 6 months for each one, and then they can grow and they can start expanding out. I had no idea this is what was going to happen when we started this clinic. I had no idea I would learn so much from the providers that come into this clinic, and from the many healers that are here together. And it's a complete honor and privilege to do this work. Thank you for letting me share our story with you. I am going to open this up to questions. I know you might have some questions. I can't see the chat box. So Kristen, if you want to kind of facilitate the question and answer, I'd be happy to do that with you.
Thank you so much, Tara. Wow. So it's just, I just think there's so much here that you haven't even told us in terms of what you have been doing. The work you have been doing is just amazing. It's really awesome. So thank you for sharing it with us.
Thanks.
Yeah. So I am thinking that everyone was so engaged as I was that we didn't have people typing away in the chat box, but we have someone saying incredible. Thank you so much. Is there anyone who wants to unmute yourself and ask questions? I certainly have one or two if no one has any. You can unmute yourselves. You can share your video if you'd like. Mickey Gilmore is saying, wonderful work, great presentation.
Oh, thank you.
You are doing wonderful work. 25 years is all it takes to be a senior midwife. That's a short time. You're in a state that already has all kinds of licensure and regulation and malpractice insurance and all of those things. As we go here, I may well come looking for advice, because we have none of that here as yet.
Where are you?
I am in Missouri.
Okay. Yeah. Okay. I'm happy to be a resource. This is my website and my email. So I'm happy to take emails and phone calls. Mm-hmm.
And for anything that, Tara, that you're feeling overwhelmed, that you feel like you need help, I'd be happy to help people with some of the logistics stuff about like how we got liability insurance and access to Medicaid in this state and whatnot too. Just if you're feeling overwhelmed, don't feel afraid to send something my way. There's expertise that you have that I don't have at all. And then if there's ways that I can help you communicate with someone about the other pieces, I'm happy to do that.
Thank you.
So we've got some things here. Let's see. Kaylee or anyone, do you want to unmute yourself and say something? Please feel free.
And use the video so I can see you.
And I think actually, Tara, if you actually stop sharing your screen, then the videos will come up more too. That might be part of why you can't see them.
Okay.
And then for anyone who doesn't know, there's a gallery view usually in the top right where you can kind of see everyone if you want. And then that makes it easier to see the chat as well for folks.
Oh, thank you.
So Kaylee was saying, in addition to the amazing work you're doing for your clients, she is just saying she just loves what you're doing to support new midwives in your community. Yeah. I'm wondering, Tara, if you can talk a little bit about how some of the funding has come about. I mean, you alluded to your amazing grant writer and everything, but you know, did you start building relationships and then funding came, or you know, how does that look?
Yes and yes, and a lot of yes. So number one, our biggest supporters started off consumers. So the families who really enjoyed our care and liked what we did were the ones that were telling their friends. And then when it was time to like start a GoFundMe, we raised $7,000 in like 2 days to build our first Speedy Mart build out. And the money goes really quick. So it didn't do much. And really, I was afraid that we were going to have to close down about 2 years ago. And then our fiscal sponsor at the time was Open Arms, and they're the doula organization. So it was actually the doulas that floated us for a while, and we could use them as resources and as a name. And then it so happened to be that the executive director of that organization took over the director job at Best Starts for Kids, which was it was a levy that was from the city where everybody had to pay an additional, I think, $1.65 per month. And it created a $24 million bucket for all these small organizations to request money from prenatal to 5. So this Best Starts for Kids levy is really changing the whole dynamic here in Seattle and in King County, because now they're funding small projects like us. They're looking for grassroots organizations who are working in families of color to go and do the work, and they know how hard it is. So, this funding is all going to be gone in 4 years. So we're doing the best we can right now. So we have 2 years to get to this next level. And so now I have to start thinking on a more broader level and constantly going after more grants to build up what we have. So just to throw out some numbers, we were operating on a $10,000 budget a year, and that just paid our malpractice insurance, general liability, and we had a very small rent in a tiny little place. We got our first grant from Best Stars for Kids, and they gave us almost $400,000. And so that's to fund this birth bundle project. So this is the first time in 5 years that I was ever paid a paycheck. For this whole time, I had been doing the work by volunteer. My husband wanted to kill me because this work it's 24/7. You're on call. I've been on call for 5 years, well, almost 10 years now. But this grant launched us to the next level, and then we ended up getting another $400,000 grant, and then a couple $30,000 grants that started to come along. And then when the city saw what we're doing, and we said we need a birth center, they're like, okay, we'll give it to you. And so they gave us $217,000 just to do the design work. And so just to make sure that we're doing something that is community-based, that's led by the community, and that will continually bring more providers of color into the workforce. So in 2 years, we went from 10,000 to 400,000 to over $1 million of operating. And there's still more money out there, and I think it's just being in the right place at the right time, going after money that you can deliver. And here's the thing, midwives are the key to all of this. Midwives have the flexibility to go anywhere you want and bill for it. If a mom had a baby out on our light rail, our midwives could catch the baby, wrap her up and send them home, take an Uber home, put her in bed, and then turn around and bill $2,000 for that. And so the flexibility that midwives have to take your scope of work and improve outcomes is amazing, and it's so powerful. And if you take what and partner where the gaps are. Our biggest gap is that the moms here don't want to have a home birth. One, their homes are not fit for a birth. They live in roach-infested, rat-infested houses. They have 6 kids in 1 bedroom. They can't do a home birth. And these moms need a break. So when they go to the hospital, it's their 2 days to rest. And so that was our gap. The moms don't want a home birth. So, and they don't want to go to a birth center and get in the car after 4 hours and drive home. That's the last thing they want to do. So we have to meet them where they're at. Means they want to go to the hospital, but we need them to go to a safe practice. We need them to find a doctor who's going to be safe, who's going to trust us, that when we call them and say, hey, I have a situation, we're not going to get yelled at. And we're not going to get, our license on the line because they don't trust us. So now, we're talking to physicians who really value our work that we're doing. We found physicians who understand midwifery care. She came to us for postpartum after her baby, and we're actually speaking together at a physicians conference in May to talk about this birth bundle project from the view of the physician working with midwives. So there's this level of trust that you have to build with your physicians at your hospital. And it means you got to give good care. You have to be excellent providers. You can't show up with a train wreck. You have to make sure they know this train wreck is coming in. They have to know as soon as you can. If you see labs that are changing, call them early. They don't want to have to deal with a mess. They want to be your help. They would rather walk you through, guide you through this. Every one of the physicians we work with are on my cell phone. We all text, we Facebook message, we figure out what's going to happen before we show up to the hospital. So, if you can really work on your skills, your collaboration skills, it's a lot of humility. We kiss a lot of butts over here. We go above and beyond for our people, for our clients, for my funders, for anyone that I'm asking for something. We go above and beyond, and we try to give them everything they need. So yeah, that was a loaded question. Sorry.
It was great. Yeah, thank you. Letting us know. I see that. So exciting to see Terry here. I don't know if you want to talk about that a little bit, or maybe just say hi, Terry.
You told me not to ask you to talk, but I'm going to.
Oh, if she said no, we don't have to ask her. That's my fault.
Terry, do you want to just introduce what you're doing with the clinic? Oh, you're on mute.
Okay. Hi, everyone. I just recently got on board, but 2 months ago? 2 months? Yeah. There's a lot happening right now, and it's really exciting. And I'm just starting to find my footing on how I fit in with the organization. They discovered some of my other skills, so now they're utilizing some of my my skills from my previous life before midwifery. So I do a lot of marketing, a lot of just admin work right now. I'm in the process of getting licensed as a midwife. So once I'm licensed, I'll come on as a Rainier Valley midwife, and yeah, just see where that takes me. I got to work on my speaking skills, so this is probably a good practice. Not my most favorite thing to do, but it's exciting. I love learning. What they're doing in Seattle is exactly what I want to do in Olympia. So it's really where my heart is. The hardest thing for me through midwifery school is not being able to practice underneath a midwife of color. And so now is my opportunity, and I'm so excited to learn and grow and figure out who I am as a midwife.
Thank you.
So exciting. Yeah. That reminds me, actually, because of what Tara mentioned, So I'm wondering about this, the sort of issue of extended postpartum care. And I'm wondering if we need a legislative fix or a rule change to be able to make sure that it's possible for families who want to stay at the birth center to be there with a postpartum doula, right? So anyone who doesn't know how our laws in Washington work is we don't have extended postpartum care in our birth centers. So people have to leave when the midwife leaves, you know, after 2, 4, 6 hours. But there's no reason that we couldn't have extended care. Tara, do you have a sense of what we would need to make that happen? And if not, we can just keep talking about it. But
well, so I get to dream my dream birth center, right? And so that's been coming up where we have, you know, birth suites, and then we have a postpartum floor, and we just hire nurses to run the postpartum units, and then we use our midwife on call when there's people that are in the postpartum. The big thing is I don't know the billing. I don't know how that all works. So that's things that we're gonna have to go into. But I don't think a doula, a postpartum doula, would be the appropriate person to stay. I think it'd be probably an RN. But that's a good train of thought to think that way.
well, if they're low risk though, and they could go home,
Then they could just, yeah. I wonder what the liability would be at the birth center, having somebody, yeah.
these are important questions. And I know there was something happening in Tacoma. So it's just, you know, these are really interesting to think about. But maybe even before you're finished with your actual building, right? Because
It'll take a few years.
yeah.
Can I just say that I think Andalus that had that model, right? Where they had, and I wonder if this is what they did with their billing. They had a lactation specialist or a lactation consultant also be that postpartum care.
Oh, interesting.
Yeah, so I'm not sure that'd be a good contact to figure out what they did and how they build. But I know they did a 2-day stay. Mm-hmm.
Good. Well, thank you. I don't want to take over. Is there anyone else who has a question? We're coming to the end of our time here pretty shortly, but we have time probably for 1 or 2 more questions. And I guess the other thing that I think you've told me, Tara, but it's just about collecting data. What are you using as a place, or how are you doing data collection?
So we have surveys, and then we actually hired out an evaluation team. So they're the ones that are holding all of the data. So we do the data. They write up they keep the database for us. So I don't do it personally. We have our admin staff does the actual data collection. So, but then the evaluation team is the one that will give us all the results and help us find the different identifiers that are working. So it's a whole nother brain to have somebody look at all the work that we do and say, whoa, this part is working, this part is not. You need to do this. This is the things that don't make sense. And then we rewrite our surveys and then we figure it out again. So yeah, that's a big piece of what we're doing. But what has been helpful is having the evaluation piece part of the planning process. So if you're going to start a program, it's really nice to know how you're going to measure your outcomes while you're starting the program. Because another one of our grants, we've been planning and they've left the evaluation to the end, and it's so much harder to do a grant that way. So if you have the ability to do your evaluation with your planning process, it's so much easier to do the reports, and it's so much easier to show the data when you want to get more funding. And that's what's going to happen. If we want to continue this after the grant runs out, we have to show along the way that we're doing what we said we're going to do. So, you know, this birth bundle project has been really fun to work on. I've never done a project like this before, and I'm learning about evaluation. I'm learning about putting a program together. And we actually were taught by the Frontiers of Innovation, which is a team from Harvard University came out to Seattle, and they taught us how to do this. And we used the theory of change model and to do an innovation. And so they're not really looking at what's our breastfeeding rate and what's our preterm rate. They're looking at how are we building this project? How is the birth bundle coming together? And then what things are not working that should have worked better? Like when I said, you know, we introduced the doulas at 36 weeks and we found that's too late. Those are the things that they're trying to evaluate. Why? You know, they want to know, how can I make this easier for anyone else? Because our big goal is to be able, in 2 years, have a packet to do a birth bundle and give it to you in Missouri and give it to you guys all over the United States and say, here's how we did this project. This is an easier way. And these are some of the problems that we came up with, and how did we solve this? And it's not a cookie cutter. It's not something that every single community can implement, but there is a framework that can make it possible for all of you to do the same thing, and practice safely and build the trust with the physicians in your neighborhood. And then also build the trust with your clients in your neighborhood too.
Awesome. Yeah. You are reminding me also to keep in mind that if you want to work with an MSM or an, you know, one of the students at Bastyr in the maternal child health systems program, because they might be able to help you with a project if you have a project that you know you sort of need someone else to be doing, or if you want to try to be publishing something specific, you know, that could be a real access point. And then at the Midwives College of Utah, there are master's students as well. And so they are doing projects as well. So just keeping all that in mind as you're like, I need somebody to do this, you know? Yeah.
The Seattle U nurses are here helping me too. So if you know anybody who's looking for a project, have them reach out to me. Because so far I have 2 Seattle U DNP nurses, Doctor of Nursing Practitioner, who are doing projects in our clinic. And then, so I'm happy to take people on if they want to take a small piece of our project. Yeah.
Hi, my name is Anne and I'm a student at Bastyr University.
Hello.
A student midwife. So I just wanted to let you know that they just started a dual midwifery and public health track. And so if you're definitely looking for help, like Kristen was saying, definitely reach out to Bastyr.
Okay.
Thank you for what you do.
Oh, you're welcome. I have 2 public health nurses right now with their BSN, and then somebody from Gonzaga just called me, and she's helping me with running the listening sessions. So if you have a classmate who wants to help out with the listening sessions on doing these birth centers, a community assessment of the birth center in this area, let them know that's going to happen in the next year, over this next year.
I'll definitely pass along the word.
Thank you.
Thank you.
One quick question, Ann. Terry was wondering how long the dual MPH midwifery track is.
So I'm the first one who's kind of doing it, and so I did the first year of public health, and now I'm doing the second year of public health and the first year of midwifery. So I think what they're gonna do is try to do the public health in 3 years, and sort of how I'm doing it. I don't, did that answer the question? I'm not sure.
So roughly 3 + 1 year?
So it would be first year of public health. So it'll be about 4 years.
Okay.
Yeah. 3 years. Yeah.
All right, everyone, thank you so much. I really love thinking about all the ways that this can be brought to other areas of the country. Thanks, Janet, for thinking about Missouri, and for everyone for being here. I want to make sure we let Tara get back to the rest of her day, and just remind everyone, I'll quickly just remind you again, if you want to put on your calendars or tell other people about, we'll have our book club on January 23rd. And that's going to be the book So You Want to Talk About Race. If you'd like to join our book club, or know anyone you'd like to tell about our book club. And then February 20th is our next webinar on the topic of cultivating a sense of belongingness in higher education, because we know that a sense of belonging is what keeps people in school motivated, and then resilient and able to graduate, is that sense of belonging. So looking forward to those. Thank you again so much, Tara. Yeah.
Thank you. Bye, everybody.
Bye-bye. Good to see you, Terry. I said, good to see you.
It was really good to see you. How have you been?
I'll hope to run into you in person at Lobby Day. Do you think you'll be around this year?
Yes, I have it on my calendar. I definitely will be there.
Yeah,